Hello. Hello, dear students. Can you hear me?
Yes, sir.
Okay, good. So, how are you all keeping? All well?
We are we are fine, sir.
Okay, right. So today I'll be, speaking on peripheral nerve injuries, and as you know, many a time the peripheral nerves are injured. They are injured. It doesn't mean that they are injured just by trauma with a fracture or a dislocation. This can be a different type of injuries also, like a chronic pressure effect on a nerve. Okay, like a carpal tunnel syndrome is also a kind of compression injury, and there can be sometimes injury to the nerve because there is a burn injury. With the burn, at the deep burn, even the nerve can be affected. So this injury, peripheral nerve injury, is not essentially just injury, a physical injury. It can be injury due to thermal injury, it can be a chemical injury, it can be an injury due to an injection, a wrong injection given near a nerve by a medication which goes into the nerve, which can damage the nerve. Or it can be due to various disease conditions, like in diabetes you can have peripheral neuritis or peripheral neuropathy. There can be drug induced damage to the nerve. So this injury doesn't really mean just an orthopedic injury or a fracture or something. So this is a broad perspective of giving the injury spectrum. So with this, let's go and see that what are the various pathologies, the etiologies that can lead to injury to the nerve. As I said, it can be injured by ischemia, like there's a vascular injury, there's a loss of blood supply because of chronic, the peripheral vascular disease or atherosclerosis and other things can also indirectly lead to injury. There can be compression, as I said, the typical example being carpal tunnel syndrome, where the median nerve is compressed at wrist joint because of various compressing and space occupying lesion around the wrist. There can be tractional injuries. A typical example is when your birth related brachial plexus injury can be an example of tractional injury. Then laceration, obviously, if there is a direct injury, there's a cut injury, there's a laceration, it can injure the nerve, which is just unrolling there. It can be because of burn injuries, as I said, deep burn where the cutaneous nerves can go, even the deeper nerve can go if there's a deep burn. Damage varies in severity from transient and quickly recoverable pattern of nerve injury to a complete irreversible type of injury. And there may be a mixture of type of damages also in various fascicles of a single nerve trunk, as we'll see in the anatomy, the histoanatomy of the nerve. So this is, as you know, all we see that here is the nerve cell. Probably this is not working. So this is a nerve cell there. You can see there's a cell body on the top. There's a nucleus on that, and then you have that yellow colored, that is the axonal fiber, which is going all the way from the cell body down towards the muscle or the effect organ or the end organ. And this myelin sheath, which is actually nothing but Schwann cells. You can see individual blue colored Schwann cells, which is eccentric nuclei on the one side, and there is a myelin sheath formation which is rich in lipid, and there is a gap in between the two cells, one cell, that is the node of Ranvier. Okay, but when there is a damage to the nerve, there is a loss, there is a demyelination, there is removal, there is damage, there is disappearance of the Schwann cells, and the myelin fibers are gone. As you can see, this is a sign of degeneration, and this is known as Wallerian degeneration. And the signal, like an electrical signal that passes from one cell to another, once this axonal fiber is damaged, once the myelin sheath is damaged, this is disrupted, and this can undergo degeneration, where the WBCs, the white blood cells, they will engulf and eat away all these dead cells. So the normal axon and target organ, like skeletal fibers, skeletal muscle like striated muscles, This can be, following nerve injury, the distal part of the axon, they disintegrate, they degenerate, the myelin sheath break up, the nerve cell nuclei become eccentric, and Nissel's granules or Nissel's body, they become sparse or they kind of disappear. And this is known as chromatolysis. This is known as chromatolysis. Now, new axonal tendril in the repair process, this is up to the degeneration parts. This is called Wallerian degeneration. Now, the regeneration also starts, particularly when the degree of injury is not very severe. There is always an attempt at regeneration. That is by a Wallerian regeneration process. So what happens in that? The new axonal tendrils, just like roots of the tree grow, the axonal tendril grow into the mass of the proliferating swan cell. Whatever tract is already degenerated, WBCs are eating away, that is the pathway which is followed by this axonal tendril. They travel along, and there is also proliferation of the swan cells which disappeared. One of the tendril will try to find its way into the old endoneural tube, and the axon will slowly regenerate. So this is the way of Wallerian regeneration. Let us see here. You can see in the figure A, you can see how the Nissel's granule disappear, chromatolysis starts. There's an injury there in figure B. In figure C, you can see the WBCs, the white blood cells, the phagocytes, they come with the black large nuclei. They come, they try to eat away the dead cells, the damaged cells, and there is disappearance of the demyelination, disappearance of the swan cells. And later on again, the new tendrils, they start developing, and they try to again reconnect to the original end organ, just like skeletal muscle, for example. So this is Wallerian degeneration and Wallerian regeneration. So if you see here peripheral nerve, now coming to the anatomy, if you revise it, you find the peripheral nerve is basically made up of an axon and connective tissues. These connective tissues are endoneurium, perineurium, and epineurium. These are the various coverings, just like dura mater, pia mater, and arachnoid mater. The nerve trunk, as you saw earlier, can be myelinated fiber. That means with swan cell covering it, or it can be sometimes, some areas it can be unmyelinated fiber also. This myelin is nothing but protein lipid complex. They insulate the layer and they increase the rate of conduction like electricity. Okay. So this is what saltatory conductions, where the signal jumps from one node of Ranvier to another node of Ranvier. That is how I think you know it from physiology. Okay. Myelinated nerves are separated by this node of Ranvier, and all these points, the axons are bare. Impulses jump from one. This is called saltatory conduction. Conduction is in unmyelinated fiber is slower and dependent on the diameter. The bigger the diameter of the axon, faster this. If it is like, for example, chronic pain, it is carried by unmyelinated small fiber. They are very slow, boring pain. This is the example of how the nerve they behave. Now, the damage to the cell body, axon, myelin sheath, connective tissue, blood supply, you have all seen that. There are three phases of this basic process I showed you earlier: Wallerian degeneration, axonal degeneration, demyelination. This is the stage of degeneration. And various type of injuries can be classified as neuropraxia, which is milder form, which is a reversible form of injury. In this injury, sometimes can happen like Saturday night palsy, very famous ulnar nerve palsy, when your hand is lying on the arm in the chair on the side, and the ulnar nerve is under pressure, and in the morning the hand may not get up because the ulnar nerve has undergone some temporary reversible injury, which is known as neuropraxia, and after a few minutes to hours it will recover. Okay, so this is reversible. Next serious severe type of injury, axonotomy, when the axon itself is actually physically injured. So this is little more higher than the neuropraxia. It is usually reversible, okay, depending on how the treatment is given. Neurotmesis is complete transaction of the nerve. That means complete when the one nerve becomes two pieces, then it is neurotmesis. Okay, so this is grade 1, grade 2, grade 3. You can say grade 3 being the highest, grade 1 being the lowest. Now this is called the Seddon's classification. This is the whatever classification I have just shown. This is a simple classification. It's called Seddon's classification, and this was done in 1942. He coined the term neuropraxia to describe a reversible physiological nerve conduction block, as I said earlier, in which there is loss of some type of sensation and muscle power, followed by spontaneous and usually full recovery after a few days, weeks, even sometimes minutes to hours also. But usually it takes days. It is due to mechanical pressure causing segmental demyelination. So there is a segmental demyelination, that is the pathology that happens, and is seen typically in crutch palsy, the pressure paralysis in state of drunkenness, as I said, Saturday night palsy, and mild type of tourniquet palsy. Tourniquet is a common device that you use in orthopedics to tie around the limb, to decrease bleeding during your operation. But sometimes if the pressure is excess, or if it is not properly applied, or if the duration of tourniquet, which is usually half an hour to 1 hour maximum, if we keep it for a long time, this can lead to paralysis of the nerve. Now, Seddon's original classification is neurotmesis, which meant division of the nerve trunk. Such it may occur in open wound, for example, open fracture where the nerve is directly injured. It is now recognized that severe degree of damage may be inflicted without actually dividing the nerve. Like, for example, if you pull a nerve, the nerve might look intact from outside, but actually nerve is injured by traction, for example. If the injury is more severe, where the nerve is in continuity or not, recovery will not occur. So that's why some brachial plexus injury, where the brachial plexus might look continuous, but there is a paralysis because of traction, some of them may not recover. As in axonotmesis, there is a rapid Wallerian degeneration, but here the endoneural tubes are destroyed over a variable segment, and there is scarring. So once there is a scarring, the axons cannot find the way, because this scar will prevent the path. They will block the pathway. They will be like a barrier tissue, so that the axon cannot reach the original target, and that's why the patient may not recover from the even though there is regeneration attempt, but it is insufficient to go and re-innervate the end organ. Now this is Seddon's classification, little more complicated, but don't worry. Okay, so you don't have to remember everything. What basically in this figure you can see is, here in below you can see Seddon grade 1, 2, 3, 4, 5. Again neuropraxia is 1. Axonotmesis, again they have divided into 2, 3, 4, means A, B, C you can say. So axonotmesis can be a mild, moderate, severe in itself. So Seddon Sunderland has graded this 5 classification, and they found that if you see on the left side, epineurium, perineurium, endoneurium, axon and myelin. If only myelin is injured on your right side, there can be full recovery. If axon is injured, there can be full recovery. But once endoneurium is injured, once the endoneurium is injured, the recovery may be incomplete. Once perineurium and epineurium is complete, that means it is almost going like a neurotmesis. The chances of recovery is nearly none until and unless it is surgically treated or nerve grafting is done, some advanced surgical intervention is done, it may not recover. Now classification of nerve injury is coming to again, as I said, first degree, it is basically neuropraxia, as I said. Second degree, it corresponds to Seddon's axonotmesis, but out of which it is usually a milder form of axonotmesis where full recovery is possible because the endoneurium is intact, okay, and regeneration takes place. Third degree, worse than axonotmesis, endoneurium is disrupted. So chances of reaching the target is good, but fibrosis may be there and recovery may be limited. Okay, so this I will not go into detail. I have already discussed this. Now, what are the symptoms of peripheral nerve injury? We know that the function of nerve is to carry sensation from the periphery to the central nervous system, and also carry command from the central nervous system to the peripheral nervous system for motor function, for example. There may be other important functions of peripheral nerve which also might carry autonomic fibers in it, but more important is sensory and motor in this case. Now there can be negative symptom, there can be positive symptom. If you have a large myelinated fiber disease like loss of touch and joint position sensation, proprioception, leading to difficulty in discriminating texture, Feet and hand feeling like cotton wool. Sometimes you will find patient will say, he will complain that when I am walking, I feel like I am walking on cotton wool. Gait might become unsteady through loss of position, sense of position, or this proprioception. That happens in large myelinated fiber when this type of nerve is injured. Now, what happens when small unmyelinated fiber is involved in nerve injuries? Usually, this is in chronic diseases. Loss of pain sensation and temperature appreciation. There can be painless burn and trauma and damage to the joint, like Charcot's joint. That means the Charcot joint is advanced arthritic changes, very rapidly changing, rapid arthritic changes leading to destruction of the joint, and there is swelling, distension, destruction of the joint. This is called Charcot's joint. This is commonly seen in diabetic neuropathy in the foot and ankle area. Okay, resulting in painless deformity, but this can be very disabling sometimes. Okay, so these are the negative type of symptom patient can have. So what are the positive symptoms? Positive symptoms, and whether it is large myelinated fiber disease that causes pins and needles sensation, pins and needles paresthesia sensation. Okay, small unmyelinated fiber disease produces painful positive symptom like burning sensation, dysesthesia. That means when you touch, even gentle touch, it will cause pain. There can be hyperalgesia. That means you give small pain stimulus, it will cause the lowering the pain threshold. That means even if you squeeze or even if you prick, the sensation will less. So patient will injure the leg or the hand which is having a paralysis or a loss of sensation, but they will not feel. So there can be infection, there can be ulceration, there can be burn. There can be hyperpathia. That means pain threshold is elevated, but pain is excessively felt. Both patient cannot feel, but when patient feels the pain, it is excessive. So there is abnormal sensation basically. So there can be lightning pain, sudden, very severe shooting pain. This can happen. Okay, like this is seen in tabes dorsalis in late syphilis cases. These were very called Lee-Hermitage sign or lightning pain. There can be motor symptoms. There can be weakness in the muscle that was supplied by the nerve. Okay. Sometimes it can be proximal difficulty climbing stairs or combing the hair that involves the upper limb. Cramps and twisting of the muscle. This happens because of fasciculation. When the muscle is denervated, now the muscle tone may not be maintained and muscle might get abnormal action potential happening here and there because of lack of control, and this leads to fasciculation. And more commonly due to neuropathies like diseases affecting the anterior horn like motor neuron disease, it can happen. Now, what are the signs of peripheral neuropathy that you can see in various type of nerve injuries in various disease conditions, not exactly trauma, but because of say diabetes neuropathy. Large myelinated fibers are involved. There can be loss of sensation of light touch, 2-point discrimination. There can be loss of vibration sensation and joint position senses. You know, we used to examine patients with leprosy who used to have the large, nerve involvement, and they used to have all of this problem, particularly vibration sensation. When you take a tuning fork, the low frequency tuning fork, 124, hertz, then you can find that there is an early loss of vibration sensation in leprosy. Similarly, joint position sensation also in leprosy and diabetes, etc. So these can be important peripheral. These are the signs that you have to elicit. Earlier were symptoms, right? And weakness, you can grade the muscle power and see how much power is there according to MRC grading, Medical Research Council UK grading, 0/5, 5/5, 4/5, etc. I'm sure you will be knowing all that. Okay, so small unmyelinated and thinly myelinated sensory fiber, they carry the temperature sensation and pain perception. So if these are involved, then temperature and pain perception will be altered. So in polyneuropathy, like in diabetes, for example, sometimes even in multiple myeloma, gloves and stocking distribution of sensory loss is seen, where hand and feet are usually, they are the first to be affected. So joint position sense is lost, gait abnormality can be seen like ataxia, even Romberg's test can be positive. It can be compensated. When the patient is opening the eye, patient may not have all these things. But when the patient closes the eyes, and all these sign symptoms of joint position, this ataxia and Romberg's test will be positive. So motor examination, as I said, other than directly examining motor power, you can actually see the wasting of the muscle. So, for example, if there is an ulnar nerve injury, you will find the interossei muscle in the hand is they are wasted. So they will be finding that these are flattening of the areas where you have the important interossei and the lumbricals. Now, weakness in the muscle you can assess by grading the power. Depressed and absent tendon reflexes, so there is hyporeflexia. And as I said, you can see fasciculation. So there will be abnormal, contraction of muscle, which is not a symmetrical contraction, the asymmetrical kind of, very disordered or bizarre type of movement in the muscle that happens with small stimulus you give, muscle will undergo contraction automatically. So what are the, just before this, going to the test, I would say the classically coming to, radial nerve injury, one of the common nerve injured because of many diseases, particularly wrong injection, Saturday night palsy, even after surgery, after injury, radial nerve. So the classical finding is wrist drop. You get wrist drop because the extensors, wrist extensors are, they have become weak because the extensors are supplied by the radial nerve. So you will get a wrist drop. Similarly, if you have a median nerve paralysis, then this three finger, the first three finger, the first, second and third digit, that is including thumb, they are affected. So you have a median claw hand. You can have a clawing of the hand called median clawing. If you have an ulnar nerve injury, which is more common, you will have an ulnar nerve clawing. In clawing, what happened basically, you have flexion and the interphalangeal joint, but you have extension and the MCP joint or metacarpophalangeal joint. So this is clawing. When you have combined both ulnar and medial nerve injury, you have classical claw hand where all the fingers are clawed, as I said, flexion as the interphalangeal joint and extension at the metacarpophalangeal joint. Okay, so you can have various depression when you take your knee hammer, the Sherrington hammer, neurological hammer, then you find that there is a depressed jerks because of these are basically lower motor type of paralysis. Now coming to common peroneal nerve injury, which is a very common nerve which is lying just at the head of the neck of the fibula, you can have foot drop. So these are some very classical questions might come. What is foot drop? A short note on wrist drop, claw hand. I think you should revise these things. You can also read your S-DAS where you have a very good chapter on nerve injury, peripheral nerve injuries, how to examine them, how to document them. There are excellent chapters on this. Now, coming to the various investigation, of course, I'm not talking about, only injury or fracture related, like humerus fracture, you can have a radial nerve injury. If there is a fracture in the fibular neck, you can have a foot drop. If a person has the injury somewhere in the supracondylar fracture or a medial condyle fracture, that can have an ulnar nerve injury. Similarly, many diseases, medical diseases can also lead to nerve paralysis. That's why all these tests might become important. You can do ESR if there is an inflammatory disease like multiple myeloma, then there are many autoimmune diseases that can lead to nerve paralysis. So CRP, the urea and electrolyte routine blood test, sometimes it can be vitamin deficiency, like vitamin B12 deficiency can lead to peripheral neuropathy. Okay, so electrophoresis is one way of diagnosing multiple myeloma where you can also have nerve injuries or neuritis or neuropathy. Then one of the common investigation, which is specific investigation we do, is nerve conduction studies. Basically, you see the velocity of the electric current, the amplitude of the axon potential from the demyelinated areas, characterizing. It is something like, I can say that nerve conduction study is basically, it is a study of the velocity of passing current through the nerves. We know that electric signals, they carry the sensation, both efferent and afferent, and that is what you can measure by nerve conduction studies. Then EMG. EMG is what? It is electromyography. It is like ECG. What you do for cardiac muscle, that is ECG, electrocardiography. This is, you do it for skeletal muscle, we call it EMG or electromyogram. So these can give you various action potential which will, from just like ECG, okay, this is QRS complex, this is down, this is up, so you can diagnose. Similarly, by looking at the EMG, you can see whether there's a regeneration potential, there is a denervation potential, there is an F wave, so many other, the type of, the graph will tell you what kind of injury has happened, whether it is axonotmesis, it is neurotmesis, or it is neuropraxia. So you can have a fair idea about it, and sometimes you have to repeat it. You can do it on day one, then repeat it after 1 month, then repeat it after 6 weeks, 3 months, so that you can see the progress. When the nerve is regenerating, the type of wave will keep changing and giving you an idea that yes, the nerve is regenerating. So you can take a decision whether to operate or wait for spontaneous recovery. Okay, sometimes you get that, okay, it is recovering, but after reaching a certain thing, it has incompletely recovered, but now no progress in over a very months because EMG and CV is telling you. Then that is how you can decide that now surgery may be required to address the problem for a full recovery. Now, sural nerve biopsy is one of the most common nerve biopsies conducted. This was very commonly done, earlier for leprosy. Sometimes you don't get anything, you just do the biopsy of the sural nerve to establish diagnosis of leprosy. And many a time, this is the nerve that is selected for doing a biopsy in many other peripheral neuropathies where the diagnosis is not clear. So this will give you a fair idea about the diagnosis. Now, CSF examination can be done in certain, large-scale disease like Guillain-Barré syndrome, tabes dorsalis of syphilis, any inflammatory demyelinating disease and polyneuropathies. Sometime this may be required, but it is not directly related to the peripheral nerve injury. But yes, sometimes you have to do it. So there is a very difficult disease called trigeminal neuralgia, which is very, very distressing. Severe paroxysmal facial pain syndrome. This pain is confined mainly to the area supplied by the second and third division of the trigeminal nerve. And it is really distressing, one of the most difficult diseases to treat. So that's why I have mentioned that you must know this is also a kind of neuropathy. Most patients are, over 40 years of age, and they are usually female. And this is one of these. So here actually there is you have to give a lot of medications like centrally acting drugs like carbamazepine, phenytoin, that is an anti-epileptic drug here to control the pain. These are all centrally acting. Even intravenously you might have to give. You might have to give anti-epileptic like lamotrigine, and sometimes even surgery is needed in the brain, in the posterior cranial fossa, from microvascular decompressive surgery, in resistant cases. So sometimes these diseases can be really distressing. Bell's palsy, which is not really my domain, but this is another example of nerve paralysis that happens after viral injury, particularly herpes simplex virus. Okay, so I'll not go into detail of that. So Guillain-Barré syndrome, I'm sure it will be dealt with in neurology, in general medicine, in pediatrics. But these are type of, large scale, diffuse demyelinating disease that you should be aware of. These are the various treatment for plasmapheresis. So these are for systemic disease that involve nerve. Okay. So, yeah. So any question that you want to ask, I did not mention here about surgical intervention. Now, if you go and ask me, what do you do as orthopedic surgeon, what do you do for various type of nerve injuries? The answer is that in most of the time, the nerve injury is either neuropraxia or axonotmesis. So treatment is usually conservative. If there is a fracture, you address the fracture. You fix the fracture. Make the limb stable. Let the nerve get a friendly environment for recovery for a Wallerian regeneration. Okay, once you establish continuity of the bone, once you give stability, once you immobilize the limb well, the nerve automatically regenerates to Wallerian regeneration in most of the cases. If you find it is frank neurotmesis, the nerve has been cut directly, the only way left is to repair them directly by suturing. But while suturing, we must make sure that the nerve fascicles are matching with each other. Okay, the fascicular arrangement of the nerve, they must match each other, then only there will be a good recovery. I will give you the further explanation. Say there are 5 motor fibers, there are 3 sensory fibers. You must, while rotating, while repairing the nerve, you try to match the motor fiber with motor fiber and sensory with sensory fiber by understanding the microanatomy. Often operating microscope is required to match the fiber. This is called fascicular repair. Okay. Sometimes there may be a big gap. The nerve may be half, some part of the nerve is actually lost or completely damaged. So you have to cut the ends, freshen the end, get a sural nerve grafting or a nerve grafting from other area of the body, put cable grafting in that area, suture them together, and then hope for recovery. Okay. So that is in extreme cases. Sometimes, say, I will give an example of a fracture of humerus in the spiral groove with a radial nerve injury. So what do? If it is a close fracture, you just treat the fracture. If you feel the fracture needs to be treated with a plaster, you treat with plaster, immobilize. If you think this fracture on day 1 requires surgery, do the surgery, fix the fracture with whatever appropriate implant, plate or screw or whatever, and immobilize it and wait for at least 3 months. Do not explore the nerve. It is not required to see the nerve if it is a close fracture. After 3 months, if the EMG NCV study tells you that there is no recovery, then only you should go and explore the nerve. So most of the time, as I explained to you, most of the type of injuries, related nerve injuries in orthopedic practice, usually the first line of treatment is conservative in closed fracture. In open fracture, where you can see the nerve getting directly damaged, then the scenario is different. You go for a primary repair. So you go for a primary repair. Sometimes you go for a repair called delayed primary repair. That means what? On day 1, you know the nerve is injured, partially injured, or they are transected, and the wound condition is not good, patient condition is not good, patient is serious, whatever. So you just tag the nerve to some tissue for easy identification with a colored suture mark. And once the patient's condition improves, once the wound condition improves, then you go for a repair of the nerve. This is called delayed primary repair. Okay? So, and sometimes you go for secondary repair. That means you wait for a long time and then you go for the repair of the nerve. This is secondary repair. But whatever repair you do, you must match motor fiber to motor fiber, sensory fiber to sensory fiber for good realignment of the fascicles of the nerve, so that their Valerian regeneration leads to good outcome in terms of sensory recovery, in terms of motor recovery. So if sometimes despite all this it is not possible to regenerate the nerve, what do you do? In the brachial plexus, sometimes it may not recover. So one of the way of doing this is called neurotization. That means you cross connect another nerve to the brachial plexus. Okay? And then try to retrain the patient, retrain the muscle by various physiotherapy to regain the lost function. This is known as neurotization. Neurotization. Okay? But sometimes all this thing will not work. Patient, that particular muscle which is paralyzed is not going to recover. So in that case, we have 2 options. One is tendon transfer. Say for wrist drop in radial nerve, it has not recovered. One way is to take a flexor tendon, bring it dorsally and transplant it to the paralyzed tendon and retrain the patient. Commonly the pronator teres can be transferred to extensor carpi, radialis longus and brevis, and then once the patient is trained again, the pronator teres can extend the wrist. So this is called Jones transfer. Similarly, the thumb is also gone, so you can transfer the flexor tendon to the extensor tendon. The flexor tendon should have a good power. That means that is not involved, and that is transferred to dorsally and tied to the tendon end of the paralyzed tendon, and that will act to extend the thumb. So these are examples of tendon transfer. So sometimes you have to do tendon transfer, and usually it is done after 9 months to 1 year when you are sure that nerve is not going to regenerate. Okay? So that is how we do a tendon transfer. Sometimes even tendon transfer is not possible, particularly when all nerves are involved, like when both radial nerve and the median nerve is involved and both has not recovered. In that case, you might have to fuse the joint in a most acceptable functional position, and that is known as arthrodesis or fusion of the joint. Sometimes you might have to do that when you know that there is no viable strong muscle to do even a tendon transfer. In those cases, you have to fuse the joint in the most acceptable position. So this is known as joint fusion or also known as arthrodesis. So you might have to arthrodese the joint in a most functional position according to the need of the patient. So this is all about nerve injury. In short, nerve injuries are common and difficult problem. They can involve the motor and sensory, or they can involve both. It can be mild, moderate, severe. As you said, neurapraxia can be mild, axonotmesis is moderate, neurotmesis is very severe. Depending on severity of the injury, the nerve is to be managed. In severe cases, surgical intervention may be required in day one, or sometimes it is delayed primary repair, sometimes it is secondary repair. In case of mild and moderate cases, it is often managed conservatively, addressing the fracture, addressing the dislocation, waiting for 3 to 4 months, doing EMG and NCV studies, follow through, repeat it and see how the patient is clinically examined for something called Tinel sign, where you actually do percussion along the nerve and get sensory sensation, and you can actually Tinel sign can be an important clinical sign like an EMG NCV, which will also give a good idea of recovery. So you do clinical reassessment, you do NCV and EMG reassessment after 3 months, after 4 months, after 5 months, and see whether it is recovering. And then you decide. If it takes too long a time to recovery, you might have to operate, or you might have to go for a tendon transfer if there is no hope of recovery and you have given enough time. And sometime in extreme cases, you might have to go for arthrodesis or fusion of a joint when you know that these nerves are not going to recover. In extreme cases where you hope that nerve may recover, you might have to go for a nerve grafting operation or cable grafting by taking a nerve graft like a sural nerve graft from the patient and implanting it there under operating microscope. Okay, so I think this is enough for today, and please revise and read as thus the peripheral nerve injury. Thank you very much. You can ask me any question if you want.
Sir,
Sir,
Yes, yes. Yeah, please ask me.
sir,
Yes.
sir. After the repair of the nerve, like you said, there will be regeneration. So, how much time does it take for that regeneration to take?
Very, very good question. Actually, what will happen for every 1 centimeter, every growth of every, for the Wallerian regeneration to take place, every day there will be growth of nerve by around 1 millimeter. That means for 1 centimeter, you need minimum 10 days, right? For
Yes.
every millimeter, one day it might grow 1 millimeter. So depending on where the nerve is cut, that means more proximal the nerve cut is, it will take longer period, longer duration to recover. So if you have an injury, if anybody has an injury of sciatic nerve at the level of the greater sciatic foramen, it has to travel the whole leg. That means it is going to take many months, and sometime it will fully recover because of so many things I said, that scarring problem, the distance it has to travel. Like when you travel a long distance, you might lose the way. You might go astray wrong way. Similarly, when the nerve has to travel very long distance, then there may be a problem. There may be incomplete recovery. They might, on the way, there may be scar, and they may not be able to cross the scar. They might, go here and there, and you may not have a full recovery or incomplete recovery. So it depends what is the nerve we are talking about. If it is another thing is whether the nerve is sensory nerve, motor nerve, or it is a mixed nerve. If it is a pure motor nerve or if it is a pure sensory nerve, that means there is no axonal confusion while regenerating. That means the sensory fiber will only grow to sensory fiber. But if it is a mixed nerve, sensory fiber and motor fiber, then what will happen? Motor fiber might wrongly grow into the sensory fiber might go into motor. So there is axonal confusion, then patient may not have recovery. So this is one thing. So some nerves are notorious for not recovering, like sciatic nerve, as I said. One of the sciatic nerve, because it's the largest nerve, it is the longest nerve, it is the most important nerve for walking of the lower limb, but unfortunately, if the injury happens higher up, it may not recover fully, or it may not recover at all. So these are the challenges that we have because of the long distance of the nerve. Then there are many other things, like during the surgery, how meticulously you have repaired fascicle to fascicle, motor to motor, sensory to sensory under operating microscope, under enlargement. You must do a good job. Then there must be good hemostasis. If there is bleeding after the operation inside the nerve, that blood itself will be acting as a scar or a pressure, and the growth may not be good. So after the nerve repair, there must be good hemostasis. You must ensure good hemostasis so that the nerves are actually they're in good contact, there is no bleeding into the nerve, and the Wallerian regeneration takes place effectively. Okay?
Yes, sir.
Okay. So thank you very much, and stay safe. Thank you.